All right. Hey, folks, welcome back to the Change Physician Podcast. This is your host, Dr. Kevin, and I am here today with my co-host, Dr. Melissa Cady. And Melissa, what would you like to talk about today?
Well, I'm just going to say, and I don't know, maybe I should give a shout out to the Facebook page that I got this recommendation. So the Lady Docs of Austin, I live in Austin, Texas. I put out a post to ask them, ladies, what would you like to hear on our new podcast? And, this was, at the time of putting together the podcast. And I had so many people say, why don't you talk about compassion fatigue? And I think that's a really good topic that we should address. And I know that, Kevin, you got quite a few things that you could chime in on compassion fatigue.
Is that to say that I'm full of compassion fatigue, or?
No, you have a lot of compassion for fatigue.
I have a lot of compassion fatigue.
Maybe we should define that.
Yeah, well, let's, and that's a good place, right? So
yeah.
I'm going to, whenever I should say whenever, what I try to do when I'm entering a conversation, at least something that has some kind of seriousness to it, is I want to make sure I'm understanding the context of the discussion. And so for compassion fatigue, like I think I understand what that means. But the first thing that I did when we were just talking about this idea is I Googled compassion fatigue just to see what the definition says. And so one of the definitions is that for compassion fatigue is the indifference to charitable appeals on behalf of those who are suffering, experienced as a result of the frequency or number of such appeals. Or from the Wikipedia page, compassion fatigue is a condition characterized by emotional and physical exhaustion, leading to a diminished ability to empathize or feel compassion for others, often described as the negative cost of caring. It is sometimes referred to as secondary traumatic stress. Now, I would be, my suspicion and my bias would be that there's probably no physician out there that hasn't at some point through their training or practice experienced this definition of compassion fatigue, where there seems to be so much misery, there seems to be so much need for you that you just can't hear it anymore, or that maybe you brush it off. Maybe you've even had a patient that you had an interaction with where, in hindsight, you could have, well, I hate the should word, but maybe you probably should have been more present with. And that, I think, is just kind of the nature of the beast. It doesn't make it right or wrong, but that's also human. At some point, if you kind of think of us and from a survival instinct, there's only so much you can take based on your perception of reality and your perception of control and other factors such as sleep deprivation. There's only at some point something's going to give in order to protect you as the individual. And what I mean by that is if you are, you can only give so much before you start actually taking away from who you are and you start actually causing damage to you as the physical organism. So it's totally understandable. I don't want to say there's any judgment with this because we've all gone through it. I do think, though, is if you recognize that it occurs and you increase your level of awareness that it actually does occur, that level of awareness lets you do is starts interrupting what I would call the automatic behaviors that can be associated with this. And what I mean is if you are in the situation where you're so inundated and you just don't have the emotional energy anymore to invest or empathize and provide compassionate care, if you're not even aware that this is a thing, it becomes very difficult to interrupt that, to pause it, to stop it in that situation. Now, without that level of awareness, without a little understanding, without a recognition that it can occur in you, you're more likely to perpetuate the behavior, which means that you're more likely to go into work every day, more likely to treat your patients like widgets, like the system wants them to be treated as, and less likely then to provide that empathic care. So that's a long way to say is I think all of us have experienced it. I don't think it is abnormal, meaning it's a nature of the beast, and it's, in a lot of ways, it's a protective factor for us. But if we're not recognizing that it occurs, and you don't have that awareness that it occurs, it's going to be very, very difficult to recognize it when it occurs in you, which means you're not going to, it's going to be much harder for you to interrupt that pathway and actually to find something different and pause and take a breath and actually then return to providing good care.
Right. And I think that there's, you made me think of a few things, but it's very common, I think, to project onto others whatever is leading to that or that state that you're in. You can project or blame others, including the patient, for it's almost like taking the responsibility off of yourself. And it depends on the circumstances, but I think anytime we're stressed, I mean, just think of a couple that's maybe maybe they're not getting sleep and they're not taking care of and you could probably attest to this more with children, because I don't have children to say that I have them to occupy my bandwidth. But there's a point where everyone around you, whether it's the system, you can apply that to any system that you are within, that if that system is extracting the energy from you and taking from you, and you are not giving back to yourself, or you're not having the time for yourself, it makes it really hard to have compassion for those members, whether it's a family unit, or you could have 6 kids and oh my goodness, I can't even imagine. But even having like, at work, and you have all these responsibilities, or the volume at which you have to see patients in very minimal, allotted intervals, like 15-minute intervals, and so many. And if you really enjoy connecting, you don't get any of that. So you're not getting that back, yet you just keep giving, and there's just, everything's piling up and it just never seems like it ends. Those things remind me of sometimes when I was in my internship or residency. So, 126 hours is what I clocked the first year. We're supposed to go 80 hours a week. And that was during my general surgery internship. And I don't know how I did it, honestly. When I look back, I didn't have the same intentions as I do now on what I think is like reasonable. Like you just had to do what you had to do because that's expected of you, and you would never quit. I mean, that's like the last thing you ever do as a training physician. So you put up with a lot, but you don't realize how that impacts you internally. But when you're just trying to survive, because you'll never quit, which some people will, but I would say most, after they've acquired that huge medical school loan, you feel trapped. That's another episode. We could talk about that trap. But I think that compassion fatigue really reveals itself in those circumstances where you're just kind of put into a system that you don't really dictate the system per se. And that's what really makes you stop and think, okay, let me be aware that this is what's happening to me. And where can I exert some control in my life? And that's something I think we can talk about too, is what those options are in order to have more compassion for others in your life and your practice. And, those are just some of the ideas and my experiences that I'd had.
So, and this leads to a lot of different things. And I think it returns to, and we'll probably hit on this at multiple points because it's such a common problem, is this idea of burnout, right? Mm-hmm. And burnout and compassion fatigue kind of go hand in hand. But when you actually look at burnout, and I think this is so important because people talk and throw around the terms about burnout all the time, but then there's very few times that people go beyond like seeking what I would call root cause with burnout. Instead, they say things, well, it's EHR or it's demanding patients. And that's not necessarily true. Those can be facilitators. They can be contributors to it. But neither one of those are what I would call root cause when you're looking at something like burnout or even compassion fatigue. Instead, what I would put forth is if you start looking, and I wish I could pull this up. I can't remember. I have it somewhere, but I can't find the exact papers anymore. But if you look in the occupational medicine data from like 40 years ago, what you saw with these fields was when you had high perceived responsibility for a specific outcome, but you have low perceived control over the delivery of that outcome, that's the recipe for burnout right there. And I would also say that's the recipe for compassion fatigue, is when you feel such a responsibility for some specific outcome, but you feel like you do not have control over whether or not that outcome comes to surface. you are going to be under significant distress. That's again a recipe for burnout. It's a recipe where you at some point you have to shut down and stop caring, because if you're a human, that is it's significant in dissonance, and it's very distressful. But if you look at sort of how medicine in a lot of ways, how we perceive, and we've gone through it, where we start feeling, and we have everybody kind of external to the system saying, it starts with the ads, go see your doctor, go see your doctor, go see your doctor, go see your doctor. There's this perception that somehow as a physician that you are responsible. You are the one responsible for the health and well-being of your patient. And folks, that's not true. You are not the one who is responsible for the health and well-being of your patient. The person who is ultimately responsible for their health and well-being is the individual. Now, granted, if someone is having an acute heart attack, they're in a trauma situation and they're bleeding out all over, like, you have a responsibility to deliver your best practice of care to facilitate and enable that person to get well. But ultimately, the patient then again has to be involved in that process. Now, the reason this becomes crucial is if you're looking at healthcare in our healthcare delivery system, it's like 80% of healthcare dollars are spent on the treatment of chronic disease. So, cardiovascular disease, high blood pressure, everything else that they're seeing in most clinics. But chronic diseases intrinsically are diseases of lifestyle and behavior. Now, as a physician, can you directly control someone's lifestyle behavior? Can you push the button or poke them with something, and all of a sudden that person is going to start exercising, they're going to start changing their diet, they're going to start taking control of their sleep, they're going to start making sure that they're modulating their social relationships in a way that's constructive and not destructive? Do any of us actually control that? And the answer is no. And yet we're told over and over and over again that we have these metrics, that we have to make sure that every diabetic has this, that every person who's obese has this, that every other person has to do their screening. Now, again, we can facilitate that as much as we can, but the more you feel like that is your direct responsibility, or you're letting somebody else tell you that's your direct responsibility, you're moving down the train to burnout. So we've talked about this in a pain standpoint quite a bit, but once you've been able to define what you directly control, your little internal circle of control, your thoughts, your feelings, behaviors, and then you define what's external to that circle of control, your patient's thoughts, feelings, behaviors, and actions. The only thing that you can do now is to influence them and to facilitate change in them. And that's a very, very different mindset to have, because now you are no longer feeling like you are responsible for their outcome. Instead, you are there as more of a coach or facilitator for them to derive that outcome for themselves. So the great thing about it is, from an ego standpoint, if you don't need to be the one and want to be the one responsible for everything, is when they get better, it's all about the patient. It's like you're their cheerleader. It's the greatest thing in the world. If they don't, though, and you've done your best to provide clear, congruent, consistent communication in knowledge, and really been more of what we would call the doctor role is, which is a teacher. That's the root for doctor. It doesn't mean you ignore them. It doesn't mean you say, you throw up your hands and say, who cares? It just means, I'm not responsible for them. I'm just here to be for them. I'm here and I'm available when they're ready for me to help them. And that it just changes the nature of the beast. And certainly from a compassion fatigue and a burnout scenario, the more you see yourself as a facilitator rather than a fixer, and particularly when it comes to things that are chronic disease processes, the less burnout, the less compassion fatigue, because it still occurs, sure, but significantly less than when you think you are the fixer of the world.
Right. And the irony of all this is that if you want to be a facilitator and help people change for the better, if you have compassion fatigue, you are minimizing your capacity to connect with the very people that need the connection for them to trust you, for them to actually potentially have the capacity to change themselves. So I'm really glad you brought up those points. It also made me think about how many people think when they get to that point of this compassion fatigue and they start saying that they hate medicine and all they see is the things despise about it, and they've kind of lost touch with the things that give them joy. I even think about, you said you need to get down to the root cause. I even think about, especially in our world of where we understood pain in a different way than most people, and how you've had people with revelations of they finally understood pain differently, and like the root cause of their ability, like you said, they have this perceived responsibility, but they didn't have the understanding or capacity to help people. And when they shifted that understanding, they felt like they had more options or control of what they could offer their patients, and it was a much different experience. So I mean, that goes for any field where you shift your belief that there are more things that you can do to facilitate change, not necessarily fix them, but in essence change that interaction where it's beneficial to the patient.
Well, and what I love about the word facilitation is it also implies a partnership, right?
Mm-hmm.
And a partnership requires two invested parties. And so if you're approaching every interaction that you have with your patients or clients from a facilitation mindset, if again, you're coming from a place that recognizes that they have to be invested in as well. So if you want, and you're like, hey, I know that this is a great outcome, or I know that this is something that will help them, benefit them, then obviously you frame it in such a way that, hey, to encourage them, to motivate them to participate with you. But ultimately, if they choose not to do so, then you have to step back, relax, you plant the seeds and go on. And then, I can see somebody listening to this though, and they're going, well, we have metrics, or we have bonus structures that are set to these specific things. Well, you can have bonus structures all you want. You can have metrics as these extrinsic factors, but it still doesn't change the fact that intrinsically the only change that you can do, or the only control that you have in the situation, is as a facilitator. I mean, we don't have mind control. I mean, we don't. And I know the metrics, and I know that people write these things are a little bit kind of goofy. In the same way, I don't think that you need to neglect them completely. There's some of those metrics actually make sense if you just to have sort of a goalpost that you're trying to transform care with. But from a personal standpoint, I can also say that is the more that you kind of view things as a facilitation and more of a partnership, and the more you develop that skill set, which is, I don't think a lot of us learned it in medical school, to be honest. And we may not ultimately be the best people to do that at this time. But the more that you are moving towards this partnership with your patient, the more likely you are to make and reach those benchmarks, and the more likely you are to actually achieve those end outcome measurements that they're looking at. And as soon as I said that, it makes me want to look up the data, because I'm sure that there's something out there to either support or deny what I just put forth. So,
yeah. No, I don't know if I could add any more to that. About what you just said. I would be curious about what you're seeing on the data. That might be something to come back to as well, if it's not laid out right there.
But I guess we can end this with this though. If you are feeling significant amounts of compassion fatigue, and you're feeling like you're losing your ability to provide compassionate care, what I would do, the first thing that I would do, besides pausing and taking a break and stepping back so you have a space to breathe again, so you can reevaluate this stuff, was to very, very clearly, I would actually draw this on a piece of paper and list out the things that you are directly responsible and have control over. And then external to that is make sure you list everything that you don't have control over. And the more you can clearly demarcate that, the more we tend to recognize that a lot of the stuff that we perceive responsibility for, and we perceive we have the ultimate outcome over, is things that we don't. And again, we've talked about awareness in other episodes. The more you are aware of that, the more you can start interrupting that cascade. One of the sequelae of which is compassion fatigue and burnout.
Absolutely. Well, I think that those moments of pause, as small as they might be, are can be critical turning points for a lot of us that are so used to just being in the grind and go, and just being part of a system without really evaluating and being aware of what's going on.
Absolutely. So, well, do we have anything else that we need to add right now?
Am I the outro or you the outro?
Who would like to be the outro? Who's controlling the outro right now?
I think you're the outro.
Okay. Well, I will be the outro then. All right, folks. Well, thank you for joining us today on the Change Physician podcast. Always a pleasure to have you with us. And hope we facilitated a little change in with you, or at least motivated you to pursue a new and different thinking mindset. I am your host, Dr. Kevin Cuccaro, with my co-host, Dr. Melissa Cady, both wishing you to stay well, and we'll see you in the next episode.